Clinical pharmacology rarely resembles the neat, predictable models found in a textbook. In the emergency department, it is a high-stakes race against bacterial replication, where treatment decisions must be made hours or even days before all the data is available. Consider Emily, a 34-year-old female who arrives at the ER. She presents with painful urination, a 101.2-degree fever, chills, and severe pain when the physician taps on her lower back, a clinical sign known as costovertebral angle tenderness. The clinical picture clearly points to a bacterial infection, but confirming the exact organism and its specific antibiotic vulnerabilities in the microbiology lab will take up to 72 hours. We cannot wait 72 hours. The pathogen is actively multiplying in a highly vascularized region of the body. Any delay in administering treatment exponentially increases the risk that the bacteria will breach the local tissue, spill into the bloodstream, and trigger life-threatening sepsis. The physician is forced to initiate therapeutics without knowing the exact target. To do this safely, they must immediately classify the anatomical extent of the infection, which dictates whether the patient requires a conservative approach or aggressive intravenous intervention. The primary driver of this initial pharmacological decision is anatomical. We have to determine if the infection is trapped locally or if it has established a systemic foothold. This graphic illustrates the strict diagnostic divergence used in practice. On the left, we have acute simple cystitis, and on the right, acute complicated UTI. In simple cystitis, symptoms like dysuria and urinary frequency are strictly confined to the localized anatomy of the bladder. The infection has not moved further up the urinary tract. Emily's fever, rigors, and flank pain exclude her from the simple cystitis category. These systemic signs indicate that the infection has extended beyond the lower pelvis. Specifically, the pathogen has ascended from the bladder, traveled up the ureters, and invaded the tissue of the kidneys themselves, a condition known as acute pyelonephritis. The clinical rule here is absolute. By definition, any case of pyelonephritis is categorized as a complicated UTI, regardless of how healthy the patient was beforehand. The kidneys process roughly a quarter of the body's total cardiac output. If an infection takes hold in this high-flow environment, the dense network of renal blood vessels acts as a direct on-ramp for bacteria to enter the systemic circulation. Because the pathogen has breached the local anatomical barrier, conservative oral therapies do not offer enough immediate, highly concentrated tissue penetration. The clinician must deploy aggressive, systemic intravenous antibiotics. We are now at minute 0 in the emergency department. The patient is admitted, the vital signs are unstable, and the decision to start IV antibiotics is finalized. This diagram shows the timeline for the most rigid rule in infectious disease management. You must secure diagnostic samples before a single drop of medication enters the patient's vein. Before initiating therapy, the clinical team has to physically draw both blood and urine cultures. If a clinician prematurely hangs an IV antibiotic bag out of an urge to treat the patient quickly, they risk triggering a catastrophic diagnostic error known as a false negative. Intravenous antibiotics rapidly destroy freely circulating bacteria. Administering them before drawing cultures can drop laboratory detection rates by up to 50%. This chemically sterilizes the sample. For the remainder of the patient's hospital stay, the medical team will have no definitive laboratory data to confirm what organism they are actually fighting. Once the samples are safely sent to the lab, we can cross the barrier into step 2 and initiate empiric therapy. Therapeutics must wait for diagnostics. Modern pharmacological targeting relies entirely on our ability to grow and identify the exact pathogen causing the damage. Empiric therapy is an educated calculation. It relies on mapping the patient's presentation against the statistical probability of specific bacterial strains active in that geographic region. For acute pyelonephritis, the overwhelming majority of infections are driven by Escherichia coli and other gram-negative Enterobacterales that originate in the gastrointestinal tract. The goal is to cast a net wide enough to reliably neutralize these likely gram-negative suspects, but narrow enough to avoid using our most powerful last-line antibiotics unnecessarily. This flowchart outlines the standardized clinical algorithm used to navigate this exact pharmacological choice. We first evaluate if the patient is in severe shock or has a urinary tract obstruction. Emily is stable and unobstructed, so we move down the no pathway. Next, we assess her risk for a multi-drug-resistant infection by looking at her recent hospitalizations and past antibiotic use. She has no recent healthcare exposures, taking us further down the no path. This eliminates the need for heavily restrictive broad-spectrum agents, arriving at the final recommendation, standard-spectrum gram-negative coverage, specifically highlighting ceftriaxone. Ceftriaxone is a third-generation cephalosporin. It is highly effective here because it achieves massive concentrations within both the systemic circulation and the tissues of the urinary tract. Chemically, its molecular structure is highly defensive. It easily resists many of the common beta-lactamase enzymes that bacteria use to chop up and deactivate older first-generation penicillins. Empiric therapy, then, is the systematic elimination of patient risk factors, allowing the physician to safely deploy the most statistically appropriate defensive weapon available. Fast forward to hour 72. Emily's fever has broken, and she has stabilized on the intravenous ceftriaxone. Concurrently, the microbiology lab finishes its work. We now receive the definitive clinical document from the lab, the culture and sensitivity report, commonly known as the antibiogram. This report confirms the pathogen. The lab grew a massive culture of Escherichia coli. On the drug panel, ampicillin is marked R, meaning completely resistant. If we had used ampicillin, treatment would have failed. This resistance occurs because the E. coli produces a penicillinase enzyme. It actively cleaves the beta-lactam ring of the ampicillin molecule, completely neutralizing its antibacterial properties. However, ceftriaxone is marked with an S. The bacteria is fully susceptible, validating our minute zero empiric bet. The third-generation structure bypassed the bacterial defenses exactly as intended. The panel also provides one more critical piece of data. The pathogen is highly susceptible to orally administered fluoroquinolones. At this exact hour, the antibiogram replaces statistical probability with definitive microbiological fact, providing the evidence required for the final phase of patient management. We can now execute the most critical, yet frequently overlooked maneuver in infectious disease protocol, the pivot, also known as step-down therapy. This graphic maps the pivot, requiring clinical improvement and confirmed laboratory susceptibilities. With Emily stabilized, the team permanently discontinues the broad-spectrum intravenous ceftriaxone. We transition her to an oral agent like levofloxacin, allowing Emily to finish treatment at home. Pharmacologically, oral fluoroquinolones are uniquely suited for this step down. They possess excellent bioavailability and achieve deep tissue penetration in the renal parenchyma, matching the efficacy of an IV dose through a simple pill. Just as importantly, stepping down protects the ecosystem. Continuing broad-spectrum IV therapy when it is no longer strictly necessary wipes out healthy flora, increases the risk of hospital-acquired line infections, and directly accelerates global multi-drug resistance. The governing clinical rule states that we must always step down to the narrowest spectrum, most easily administered agent as soon as the clinical data allows. We use defensive broad-spectrum IV therapy to save the patient during the acute crisis, but we pivot to targeted oral therapy to ensure those same antibiotics will still work for the next patient.